So the workshop is Modern Medical Ethical Challenges. The field of ethics has really changed over the years in terms of the issues that we actually discuss. But I wanted to spend a good part of this workshop just giving you some tools for ethical understanding, because we can talk about specific things, and we will talk about a few specific things as we go along. But if we don't really have a context, or if we don't really have the tools to plug those into, it can be a little bit challenging. So I wanted to start off, and here's where I would use a whiteboard if I had one, but I'll spell some of these words because some of them are big. There's 4 basic principles of bioethics that everyone really should be aware of if we're having a discussion about bioethics. It's interesting because these were described in a book called Principles of Biomedical Ethics as recent as 1979 by 2 American philosophers, one being a theologian by the name of Beauchamp and Childress, not that you need to know that. But their 4 principles that we're going to spend some time walking through have become the bedrock, you might say, of bioethics discussions around the world, actually, not just in America, but throughout the Western world. So there's 4 of them, and at various times they're discussed in different orders. I put them in the order that I did because it's how I think of them, and I also think it makes some sense. So the first one is sort of a hard word to pronounce. The word is non-maleficence, or as the Brits would say, non-malfeasance. Now that's spelled N-O-N, just like N-O-N, non. Mal, M-A-L-E, like the word male, and then feasance, F-I-C-E-N-C-E. So it's N-O-N-M-A-L-E, F-I-C-E-N-C-E. Non-maleficence. You say, well, what in the world does that word actually mean? Well, it is a word that basically means first, do no harm. Now, that has been the bedrock of medical practice since the time of Hippocrates. It's thought that Hippocrates is probably the one who came up with that concept. Hippocrates was a Greek physician living in around the 300 BC, so about 350 years before the time of Christ, on a little Greek island called Kos. The Latin translation of first do no harm, doctors used to need to learn Latin, that's not a requirement anymore, but is primum non nocere, which is the translation first do no harm. Now, you might think that sounds like a negative because it says something that you're not supposed to do as opposed to a positive. I actually think it's a very positive thing because I quite honestly think about that principle almost every day when I'm interacting with a patient. Because, for example, a patient may ask me, what about this or what about that, treatment modality or whatever it might be. And if there is not a reason for me to think, or there's no evidence that that would create harm, then it satisfies the first principle of bioethics, which is to first do no harm. Now, I'm not going to make this workshop a discussion about COVID, but it's really hard for me to talk about lots of these things without at least alluding to it. So I would just ask you in the back of your mind, as we talk through these 4 things, to see how in the COVID narrative that unfolded throughout the world, every single one of these principles was violated very significantly. Speaking of COVID, if you think about the masking and the lockdowns and the mandates and all of that, which there's scads of evidence now which have been completely not only not helpful, but positively harmful. So all of those things, which we knew actually from the beginning were harmful, violated the principle of non-maleficence, or to first do no harm. Now, Hippocrates wrote quite a bit in terms of medicine, and it was collected in something, it wasn't just his writings, it was collected in something called the Hippocratic Corpus. Now, I'm sure, how many of you have heard of the Hippocratic Oath? So most of you have heard of that. So that was something that was defined by Hippocrates. It began by saying, I swear by the gods of Asclepius and Apollo, I believe it is, that basically, here's how I'm going to help patients. It's a very lofty thing outside of the Greek god reference. It specifically talked about not doing abortions, keeping patient confidentiality. Unfortunately, many medical schools really don't use the Hippocratic Oath anymore. It's considered to be, by some, dated. It's actually not. It's actually very sound in terms of ethical principles. But part of what Hippocrates gave to Western medicine is this collection of writings, not just from him, but from others of the time, called the Corpus, C-O-R-P-U-S. And there were three things that characterize the Hippocratic Corpus. The first one, and I love these things, it's very important for me as a doctor to think about them. It's actually not just for doctors. I think this applies to everyone. But the first one was close observation of symptoms. So I've often said that being a good doctor is like being a good detective. You try to go where the evidence takes you. So you observe things, and you simply observe what you're seeing. You write down what you're seeing. You're observing the symptoms. The second feature of the Hippocratic Corpus was an openness to ideas from all sides. Now, historically, that is the way physicians in particular have been trained to examine everything. This way of thinking about it, this way of thinking about it, that way of thinking about it, and discuss it, and decide which one is the best, or maybe several of them are equal. Well, we certainly saw that disappearing in training throughout COVID, where one side was considered to be correct and anything that didn't fit that narrative was considered to be false. So that violated certainly the Hippocratic Corpus. It also violated the simple concept of education is about a free exchange of ideas, with the understanding that not all ideas are equal, but all ideas at some level rise to the credibility of a discussion. So an openness to ideas from all sides, and then the third thing was a willingness to explain the causes of disease. So those are just sort of three things that I think are important in terms of this concept of first doing no harm. As I, just from a patient standpoint, let me give you a little key. A lot of patients will self-diagnose and then will come in and say what they think they have. And in all fairness to my patients, they are trying to be helpful. However, it is not usually very helpful, because here's what happens. It steers the provider's mind in a certain direction. I'll give you an example. This did not happen to me, but it was an example I was familiar with. A patient came in and talked about his reflux. He was having central chest pain, and so the provider treated the reflux. The patient went home the next day, died of a dissecting aortic aneurysm. Two very different things: chest pain that might be related to an aneurysm, or chest pain that might be related to reflux. So this idea of the openness to ideas from all sides is simply the idea that a physician, as he or she is trained, is to think about what could be the causes. And in our minds, we've come up with what's called a differential diagnosis. This would be a possibility, that would be a possibility, this is the most likely, this is the least likely. And sometimes in the press of a busy day, if a patient has self-diagnosed and say, oh, that's fairly straightforward, I know how to deal with that, you may completely miss the issue. So that's just an aside. So first, do no harm, and I often will quote this to patients when they ask me things that I may not actually know about, because there's so much that changes in the world of medicine and so much information that keeps constantly coming, and you simply sometimes have to say, I don't know. I'll go and find that out for you. But I always think, well, is this going to be harmful? And sometimes it's obvious. Well, that would probably not be a good idea. But if it isn't obvious, and there's not any reason to think that it would be harmful, it can satisfy the first principle of first doing no harm. The second one then moves to what you might call the positive. So the second one is called beneficence, spelled B-E-N-E-F-I-C-E-N-C-E, beneficence. Now that is sort of the opposite. That is to do some good. That's how I translate it. So if the non-maleficence is first do no harm, we want to not only do no harm, we want to also do some good. So that's the second one, beneficence, do some good. That one's fairly obvious. Sometimes there might be a difference in understanding or a difference in opinion of what that good might actually be, as far as what a patient might think and what a provider might think, but that's where the discussion, of course, can be had between the two. So that's the second one, do some good. The third one is a very common word, and it's called autonomy. Autonomy, I think we all know what that is. It's simply the freedom to be self-determining, or it's self-determination. Now, it's very interesting because we've had a lot of shifts in relation to autonomy. So if you follow medical ethics, from a doctor's standpoint, autonomy would say who makes the final decision in terms of a patient's health care. Who would that be? Did I hear the patient? Exactly. The patient would be the one to make the decision, because that's what's implied in autonomy. I view my job as a doctor to give people information and to help them sort through the pros and the cons of any given strategy. But ultimately, it is the patient's choice. And I make that clear with patients. It is their choice for their body in terms of, unless, of course, we're talking about a moral issue. Like, as I said that, I realized that's the argument that's used for pro-abortion, my body, my choice. That's a little different. That violates a clear category of right and wrong. But if we're not talking about a right or wrong, it's a decision of, for example, this medication or that medication, or a medication versus an herb, or treatment or no treatment, or screening for everything that you possibly can, or not screening for anything. I have those discussions with patients quite a bit, because it's like, well, you're going to get your colonoscopy or screening for, colon cancer, and some patients want to do that. We talk about, how that could be helpful. And others say, you know what, I'm not really that interested. And, as long as they understand that there could be some risk inherent in that and they're willing to take that, that's fine, because there's also some risks inherent in the screening as well. So it's, it's back and forth. But at the end of the day, it's autonomy, as in the patient has the self-determination to make that choice. Now, I mentioned in the earlier talk about the Holocaust, and of course we all know the horrors of the Holocaust, and we all know the experimentations that were going on with the Jews and other people as the Germans attempted to create this superior German race through something called eugenics and all of that. After the horrors of that were exposed, and after World War II ended, we of course had the Nuremberg trials, where a lot of the people in the medical field under Hitler were tried. Unfortunately, many of them came to America and continued to do the same experimentations in the South as they were doing in World War II in Germany. But the Nuremberg trials created the Nuremberg Code of 1947, only 2 years after World War II had ended. And if you want to look up the Nuremberg Code, it's easily available online. There's 10 principles of the Nuremberg Code, and I'm going to read just 2 of them to you. Number 1 says, voluntary consent of the human subject in the experimentation is absolutely essential. A person must give their consent. I could go down the road about the COVID shots. I won't. There was not consent given. No one realized they were needing to be consenting to the greatest experimentation in the history of medicine. There was no voluntary consent given. So voluntary consent of the human subject in the experimentation is absolutely essential. And then principle number 5 said no experimentation should be conducted where there is prior reason to believe that disabling injury or death will occur, with the exception being if the experimental scientists conducting the study also serve as subjects in the study. Now get that. Let me read it again. No experimentation should be conducted where there's prior reason to believe that disabling injury or death will occur, with the exception being if the experimental scientists conducting the study also serve as subjects in the study. I believe it was the former head of the CDC, Robert Redford, who just in the last month admitted that the CDC knew there were problems with the COVID shot as early as 2021, still continued to insist that it be had by everyone, including children. Clear violation of principle number 5, as well as number 1, and as well as all the other 8 if you actually read those codes. So it used to be that medicine was very paternalistic. I'm the doctor, you do as I say. I had a patient, he's passed on some years ago. He was one of the few patients who was an older gentleman. He had the name Joel, by the way. When I would walk in the room for his biannual visit, he would always stand up. Now, I never felt that I needed to have someone stand up when I walked in the room, but that was part of his ethos. It's just, you're the doctor, I'm standing, shook my hand, sat back down. It always made me feel quite humble, actually, to be honest. But part of that does come out of perhaps a paternalism. You know, I'm the doctor, you're the patient, sort of this hierarchical way of looking at it. When I was in training, I did my residency between 2003 and 2006. It was very much more sort of a partnership relationship. And we were taught to be very non-paternalistic. In other words, you engage with the patient, you let the patient make the choice. It's very patient-driven, not provider-driven, not doctor-driven, very patient-driven. That's the way I was taught. And again, without continuing to reference COVID, but it's very hard to not, because everything in the world, it seems like pre-COVID and then post-COVID. During COVID, we had a shift medically back to extreme paternalism, where you do as I say, and if you don't do as I say, you're not welcome here. There were many offices, if you refused to get vaccinations and so on, you were actually not allowed to come. That has never been the standard of our office. I've always felt that to be less than helpful. If I create a standard that says you can't come here unless you do X, Y, or Z, that's certainly not a way to care for people or to treat people. But we saw that en masse across the world, not just in the U.S. So we had paternalism, partnership, and then a shift back to an extreme form of paternalism. And as you can see, paternalism is the exact opposite of autonomy, which is this third principle of biomedical ethics. And then the final one of the 4 principles is something called justice. And that one's perhaps the hardest of the 4 to sort of get your mind around on a practical level. What does this actually mean? And the best way to think about justice is the greatest good for the greatest number. This will perhaps give an illustration of what we mean by this. for male patients, particularly testing for prostate cancer. I'll just use this as an example. It used to be that if a man had a PSA, which stands for prostate-specific antigen, above 4, less than 4 is considered normal. If you had a PSA less than 4, you immediately went to the urologist. They did a prostate biopsy, et cetera, to see if it was cancer. Well, after doing that for 10, 15 or more years, it became obvious that the vast majority of the prostate biopsies that were being done in men were actually not cancerous. And so the pendulum shifted way back, well, not way back, but it took a while to shift, but it shifted back to, well, if it's sort of between 4 and 10, that's maybe sort of the gray zone, we probably can watch it. And now, probably family doctors adopted that sooner than what urologists did, because prostate biopsies are part of urologists' bread and butter. However, eventually the urologists sort of came around to that as well, and many of them will follow that. Okay, that's the gray zone, let's watch and see. So that sort of follows the principle, the greatest number, or I should say the greatest good for the greatest number. And so an immediate prostate biopsy for a PSA greater than 4 fell out of favor, fell out of standard medical practice, because it was not really the greatest good for the greatest number. Does that make sense? That's sort of an example of what we mean by justice in terms of these principles. Any comments or questions about these 4? I know they're sort of philosophical categories to wrap your head around, but I think they do make some common sense. All right, so that's sort of the basis. Non-malfeasance, first, do no harm. Secondly, beneficence, do some good. Thirdly, autonomy, patient self-determination. And finally, justice, the greatest good for the greatest number. Now, let's shift to discussing a couple of basic principles. And this is not specifically related to biomedical ethics, but it certainly is a part of that. Just some principles that I use in general in relation to life, and particularly in relation to my medical practice. And this first one might sound odd, but if someone is not asking a question, they're generally not looking for the answer. Let me repeat that. If someone's not asking a question, they're generally not looking for an answer. So what do I mean by that? Well, sometimes we feel the rush to right the wrongs in the world by trying to explain everything. But if there's not that process of a patient or a person in general, even take it outside the context of medicine, if they're not even asking the question, sometimes it becomes, I say it respectfully, but a waste of time to try to give a big explanation for something that someone's not even asking as a question. Now you might say, well, does that mean then we just let everyone think what they want? Well, I think, and this is the challenge, maybe going back to what we said in the sermon, I think it's important as Christians to live lives of winsome curiosity. You simply live a life that invites questions. It's like, what is that person about? They seem to be in this world, but yet not of this world. They don't seem to be all that frustrated by what's happening in the world. Because there's a lot to be frustrated. It's very easy, if you get caught in the news cycle or the social media cycle, it's very easy to, all of a sudden have elevated pulse and blood pressure and everything because of everything that's happening. So we need to live these lives of winsome curiosity. I had the opportunity just a few weeks ago to spend 4 days in Oxford, England, with Eric Metaxas. If you know anything about Eric Metaxas, he has a podcast. He's a prolific author. This was at a Socrates in the City retreat in Oxford. And he was interviewing a Michael Ward, who is a professor at Oxford. And Michael Ward said in the interview that C.S. Lewis said that you should tell a story so compelling that people want the story to be true. Tell the story in such a compelling fashion that people want it to be true. And then you actually have the opportunity to show them that it is, in fact, true. In fact, it was C.S. Lewis's contemporary, J.R.R. Tolkien, who wrote Lord of the Rings, who, in a little riverside walk at Magdalen College in Oxford, we had the privilege to walk on this walk called Addison's Walk, because you have to understand, Tolkien and Lewis met routinely with other people in a group called the Inklings. And the Inklings was a literary group. It was a philosophy group. It was a discussion group. They met at a couple pubs, the Eagle and Child, the Lamb and the Flag, I believe, in Oxford, and they would read each other passages. Lewis would read passages from the Chronicles of Narnia to Tolkien. Tolkien would read parts of the Lord of the Rings to Lewis, and they would collaborate on this. And of course, they both studied myth, Norse mythology, medieval literature, and that sort of thing. Sometimes we hear the word myth and we think myth, oh, it's not true. From a literary standpoint, that's not exactly what the term myth means. And so one evening, on a riverside walk, about 10 o'clock at night, as Tolkien and Lewis were walking along the river, Tolkien asked Lewis, would you be willing to consider that the Christian myth is, in fact, true? And Lewis said, yes, I would be willing to consider that. And it was shortly after that, Lewis writes in his autobiography, Surprised by Joy, that he came to be a theist, where he believed that God was in fact God. He described himself in Surprised by Joy as the most reluctant convert in all of England, sort of coming kicking and screaming into the kingdom, but God had gotten a hold of him. It was 2 years later that Lewis then actually became a Christian. The story is he and his brother were heading to a zoo, the Whipstade Zoo outside London. By the way, this doesn't have anything to do with bioethics. It's just a fun story to tell. They were heading to the zoo. The women were going in a car. Lewis's older brother, Warney, liked motorcycles, so he had a cycle with a sidecar. Lewis said, all I know is I climbed in that sidecar, not a Christian, and when I got to the zoo, I was a Christian. Now, maybe that had something to do with Warney's driving, I don't know, but during that ride, he became a full-fledged Christian. Not just a theist, as in I believe there's a God, but I am now a Christian as I believe that Jesus is the Son of God and is the way to salvation. A beautiful story. I mean, it was very interesting because one of the things that Metaxas does in his interviews, if you've ever watched any of these, he doesn't just interview Christians, he'll interview atheists and agnostics and so on. The whole point of Socrates in the City is the unexamined life is not worth living, so the Socratic method is you ask questions, you invite dialogue, you have discussion. And he was interviewing a British author by the name of Tom Holland, who's written lots of books, apparently has a podcast from the UK called The Rest is History, which must be the world's most listened to podcast, according to what I've read, which is quite impressive. He wrote a huge book called Dominion, which is basically how Christianity has impacted all of Western civilization in a positive way. But the interesting thing is Holland himself is not a believer. He's an agnostic. And so at the end of the interview, when Metaxas asked for questions from the audience, the one fella from Manhattan said to the speaker, Holland, you've obviously written about Christianity and its positive impact on the Western world, and you write about all these other religions. Would you ever consider the truth of the Christian story? Now, talk about a direct question. And it was very interesting because he became almost very pensive, not reactionary at all. It was almost like his personality changed, and he wistfully said, yeah, there's many days that I'm closer to the Christian story than I ever was, and then other days I wonder if I believe that just because I was culturally conditioned. It was almost like telling a story so compelling that you want it to be true, and I saw that in the agnostic's response. He wanted the Christian story to be true. So I think, when it comes to some of these ethical dilemmas, I think perhaps a backdoor approach, maybe that's what I'm trying to say. I did a degree in counseling a biblical counseling program prior to medical school, and that was one of the things that was discussed there. It's rarely helpful to come barging in the front door, guns blazing, so to speak. It's usually better to come in the side door or the back door and invite people into a conversation. So that's the winsome curiosity. Because yes, it's true that if people aren't asking a question, they're not looking for the answer. But if it is a question that really is a matter of life or death in terms of eternity, then that actually is a question they should be asking. And part of our job as Christians, as we present the gospel to the world, is to present that in a winsome way. So a second thing that makes living in this world pretty challenging, and sometimes even bioethical discussions challenging, is most people believe what they want to be true. Did you know that? Most people believe what they want to be true. In psychological terms, I think it's called confirmation bias. I believe what I want to be true. Why do you think that is? I'd be curious. Any thoughts? I know it's true for myself. Supports your worldview, okay, right? Well, that's a good point. Back to the humbling part. It is easy to believe we're always right and not to be challenged. When you do challenge your own assumptions, or when you allow your assumptions to be challenged, or when you challenge someone else's assumptions, it throws people into a state of what's called cognitive dissonance. Now, cognitive dissonance is the state that occurs in the mind when new information threatens your previously held belief. That is a very uncomfortable place to be, because none of us really like our beliefs to be challenged. I happen to believe that questioning is a very important part of life. Some people are sort of afraid of a question. It's like, well, I don't want to ask that question because it may expose all sorts of things. It could expose the fact that I'm not even a believer. I actually think there's no question that really is off limits if it's asked from an honest perspective. But few people are comfortable with that internal state of turmoil that it creates whenever new information collides with previously held beliefs. I happen to believe that's very important. I think that that's an important part of growing. I think throughout my life, I've probably at some point questioned almost everything that I had ever been taught or everything that I believed. I think if a person does that in a safe environment, you arrive on the other side of that question with a far more settled belief than you would have otherwise. And then the third thing, before we shift into just a couple of practical things about ethics, is changing another person's mind, particularly on issues of consequence, is ultimately the work of the Holy Spirit. Did you ever know of anyone to change their mind from a social media post? The answer is no. You don't have to think about that. No one has ever changed their mind. Well, I shouldn't say that's such a blanket statement, but I'm not aware of anyone who's really ever changed their mind from a Facebook post or a social media post. Changing someone's mind is really not our job. Our job is to present information. It really is the work of the Spirit, because we do find ourselves in a spiritual war. And logic and reason can certainly help. They absolutely can help, but they're not the main point. I think good conversations with people always should engage both the head and the heart. Not just an intellectual discussion, it's also a heart response. And most of the time, as I mentioned with Charles Darwin, most of the time there are underlying questions or there are unstated assumptions that lie behind people's beliefs. And if you're engaging just the head and not the heart, in other words, what in your life actually led you to that belief? You see, now you're actually probing underneath the surface, which is back to what Hippocrates said, a willingness to explain the causes of things. There you're inviting someone to actually think more deeply about perhaps an experience in their life that was pivotal in making them believe what they currently believe. All right, so let me talk now about, in the remaining time, I just want to talk about three specific ethical issues. And, in the past when we talked about ethics, we talked about the obvious things, like abortion, the sanctity of life. And not that those aren't important. Those are very important, but they seem so obvious from a biblical standpoint that I'm sort of going to focus on just a couple of things that you might think a little bit off to the side, but yet I think are important. And the first one is, and I stand before you, of course, as a doctor, but the first modern ethical challenge is the current trust or lack of trust in the medical profession, which again has really changed since COVID. There was a study from Pew Research, December of 2021, that states, this was a survey, 22% of people have no confidence in the medical profession. That's nearly a quarter. 29% have a great deal of confidence. That's another quarter. The rest, 78%, those numbers don't quite add up actually, but 78% say they have a fair amount of confidence. So the confidence level is not really at a very great high. Now, I never did very well on standardized exams. I hated multiple choice questions, and I still do to this day. By the way, if you're a good psychologist, you can pass the medical boards simply by knowing how questions are done, and they've done this. They've had people who had no medical training whatsoever, took the medical boards for being a physician and passed them, simply because they were good test takers. That always really infuriated someone like myself who found figuring out the mind of the person who made the questions very difficult. I had a professor in medical school, he was a Scot. So he would give us quizzes, 10 questions. So you would answer the question. But in addition to answering the question, he would ask us to rate your confidence level on a scale of 1 to 10, 1 being no confidence and 10 being extreme confidence. So not only did we answer the question, we had to rate our confidence level, but it didn't stop there. If you were confident, you ranked a 10 in your answer to the question, but your answer happened to be wrong, not only did you get the question wrong, you also got docked for having a high confidence level in a wrong answer. So it was possible in his classes to end up with a score less than 0. That was very frustrating. But it did highlight the importance of confidence and how that it's important to be confident in the right thing. So unfortunately in the medical profession, we sort of find ourselves up against this quandary of people don't really trust us a whole lot. Now in 2022, just 2 years ago, a year and a half ago, there was a Gallup poll which, and this is good news for nurses. Do we have any nurses here? None that I see? Well, when asked who has the highest ethical standards in the medical field, nurses ranked at the top, 79%. 79% of the respondents said nurses did. 62% said doctors, and 58% said pharmacists. So sort of a challenging time for myself to win the trust of people, because that's where we find ourselves. And of course, There's the whole, and I won't go into this in any detail at all, but there's the whole sort of biopharmaceutical complex where, pill mills, you might say. And again, I'm not against medications. I prescribe medications all the time. The longer I practice, the more I try to find alternative remedies that would make medical sense. There is, and this is not just my saying, this has been a critique of Western medicine for quite a few years, and that is that there is a vested interest by the complex, whatever that might be, in keeping people unwell. If you can keep people dependent on your product, you will continue your livelihood, which is sounds very cynical to say that, but that's been well documented in studies by ethicists and sociologists and so on. So what's the solution? Well, possibly the solution is to find yourself a good Christian physician. You say, well, what difference does that make? Well, I pulled a book off my shelf as I was thinking about this called The Christian Virtues in Medical Practice. This was written by two authors who are Christian. And it's specifically, in the introduction to this book, the introduction is entitled, Being a Christian Physician, Does It Make a Difference? Now, it was my membership in the Christian Medical and Dental Association some years back that helped me to understand this concept, and so it was delightful to actually find this in a book by a top-notch ethicist. So I'm a Christian, I'm also a doctor. Which comes first? A Christian, absolutely. And it's not just a matter of word order. You see, if I'm a doctor who happens to be a Christian, that means that Christianity doesn't necessarily influence my worldview of medicine. But if I'm a Christian who, quote, happens to be a doctor, that makes all the difference, because I look at my profession through the lens of Scripture. And in fact, this is exactly what these authors say in the introduction. The Christian physician is not just a physician who happens to be a Christian. He or she is at once a Christian and a physician, one who is competent, but one whose competence is practiced within the constraints of Christian ethics. So I think that's more than just a matter of word order. It makes an extreme difference. And just one other thing to read from them. Let me find it here, page 75. Thus, for a religious person, the practice of medicine is a moral calling. It is transformed from a mere occupation or profession to a vocation. Practicing medicine as a Christian requires giving witness to the truth of the faith in the way one lives his or her personal and professional life. So enough of that, but that's how I think about my role. I'm first a Christian, and then second of all, a physician. So there's a lot of work for us healthcare providers, physicians, otherwise, to do to regain trust in the public, or to regain the public's trust, I should say. The second issue, you can't really talk too much about modern bioethics or ethical challenges without talking about the gender controversy. When we used to think about ethics and gender, we would talk about the obscure things like ambiguous genitalia, and that still does happen. That is, a child is born and the external morphology, or simply the appearance of the genital region, it's unclear because of embryologic development if this is a male or female. That's very rare, but it does happen. So that used to be our discussion in relation to gender, and how do you navigate that? And of course, those are very real issues that need to be navigated biblically and correctly. But it's really morphed from that to a whole new vocabulary. And it was very interesting. It was probably about 10 years ago. I took my vehicle for a service appointment, and I decided rather than spending my time lusting at the new vehicles out in the parking lot, maybe I'll just take some reading along. So I took the American Family Physician, a journal, along, and at the very back of the issue that I took along was an article on caring for the transgender adolescent. This was at least 5, if not 10 years ago. It was a 3-page article, and as I read it, it's like, interesting, but I was asking myself, where is the place in this 3-page article where it says do an examination? Because the issue of gender can be cleared up fairly quickly by a genital examination or a chromosomal karyotype. But in that 3-page article in the American Family Physician, not once did it say you should do an examination. Well, I was always taught, this is a classic text, Bates' Guide to the History and Physical Examination. Take the history. If you're trying to figure out a problem, you take the history. If you take the history well, don't necessarily let the patient guide you. Let the patient guide you, but not pigeonhole you. History. 80 to 85% of the time, the diagnosis should be clinched with the history. Second, physical examination should bring the diagnosis to light in the remaining 5 to 10% of the time. And then thirdly would be laboratory or imaging investigation, which will help with the remaining 5 to 10%. That's the classic way of medical diagnosis. It's been taught for centuries. But in the American Family Physician, in the 3-page article, it simply ignored that. So now we have a whole new world of vocabulary that we are supposed to somehow learn. The older I get, I'm 55, I realize that my brain power is limited, and there's certain things that I just choose to not use my brain power to try to absorb because it's not necessary. So there's so many terms in relation to gender. Of course, I'm sure you've heard the word cisgender. That's simply how does your gender correspond to your biological gender at birth? That's cisgender. I'm a male. Physical examination reveals that I'm a male. Everything about me is male. And that's about 97% of the population, at least of the adult population. So the idea of, you would think from news and discussions that the transgender community would be a huge part of the population. It's somewhere around 1%. 0.5 to 3, depending on how it's looked at. Now, do you know how many people have snake phobia? Well, that percent is 50%. Now, when's the last you read an article or a news article about dealing with snake phobia? That's in at least half the population. Well, it doesn't make the front page, because it doesn't have the impact that the transgender discussion does. Sometimes just simply looking beneath the surface and just looking at some simple facts helps to clarify the issue. I think it's very important on this issue that we're really clear. We take our cues from the Scripture. Now, it was very interesting because if you followed this, on Easter Sunday of this year, Biden at the White House declared that day Transgender Visibility Day. And he did so by citing the passage from Genesis 1, verse 26, that says, all people are created in the image of God. But what he didn't do was finish the passage. That is, of course, what that passage says. But then it says, in the image of God, he created them, male and female, he created them. So you can't cite one part of a verse without finishing it. So that's very clear. And if you think about it, and I think this sometimes gets misunderstood in the discussion of this, if in fact, let me just read it. God said, this is 1:26, let us make man in our image, after our likeness. Let them have dominion over the fish of the sea, etc. This is what's called the cultural or the creation mandate. So God created man in his own image. In the image of God, he created him. Male and female, he created them. So if I doubt my biological gender, it really is the ultimate fist in the face of God, because part of God's image is my gender. You can't read that passage without getting that clear message. That is what the passage says. Now, some people would say, well, does that mean you don't have compassion for people who struggle with sexual issues? Of course not. I could actually argue from Romans chapter 1 that every single person on this planet struggles with sexuality. How do I know that? Because if you read Romans 1, beginning at verse 17 to the end of the chapter, it's quite clear. The progression in there says that when you choose to rebel against God, then God confuses your gender. That is actually what Romans 1:17 to the end of the passage is talking about. Well, isn't it true that all of us have at some point, or I should say God confuses your sexuality is what I meant to say, not your gender. Isn't it true that all of us have at one point said no to God? We've all resisted God? Yes, we have. So you could make a logical case from Romans 1 that all of us struggle with genders. It's not about compassion. It's not about not being compassionate. Of course, compassion is one of the key cardinal virtues of being a Christian. So I think that becomes a little bit of a bunny trail away from the actual platform. And so Genesis 1:26 is quite clear. And if you scroll over a few chapters later in Genesis 5, it repeats that very concept. So I think that's so critical for us to have in mind. A final thing as we wrap up here in the last 5 to 7 minutes. So I asked my wife, who's home canning beans right now, I believe, I said, so what would you say, from your experience, in terms of ethical issues, what comes to your mind? Because it can be a whole host of things. You can jot out a dozen or two. And she thought for a little bit and said a few things, and then a few minutes later, she said, well, she thinks maybe one of the biggest issues that she encounters is the desire to feel good. And let me flesh that out a little bit. Does this mean we're not supposed to feel good in the world? No. What's the most common reason why people come to the doctor? Pain. I had a patient in my office yesterday who had an extreme muscle spasm. His neck was completely down here, almost at 45 degrees, and his pain level was 15, he said, out of a scale of 1 to 10, if there can be such a thing. Am I going to just say to him, well, the world's fallen, part of the fallen world is pain, just deal with it? Well, of course not. That wouldn't be compassionate. That wouldn't be fulfilling my duty as a physician. But there is a sense in which we all want to feel good. But yet we realize that we're never really ultimately going to feel good until we're translated into a new body in the new heavens and the new earth. And if you think about this, the sort of the schema or the outline of Scripture follows 4 main trajectories. We have creation in the beginning. In the beginning, God created. We have the creation narrative. But it wasn't very long until we had the fall in Genesis 3. The sin. Man fell. Sin came into the world. The rest of the Old Testament is a process of laws and sacrifices and an attempt to reconcile this sin. That was all part of God's plan, of course. But it really, the prophets, told people what they needed to do, but people didn't listen. And so we finally have the third of the fourth part of the schema of the Scripture, and that was redemption. So we have Christ coming. Christ comes as the atonement. So we have the beautiful story of the gospel, reconciliation. But it's not finished yet. It's not finished until the final curtain falls, you might say, or curtain lifts, depending on how you look at it, and that is the ultimate glorification when we're finally translated into that state where there is no more tears and no more crying and no more pain, as Revelation talks about. And you know, when man sinned in the garden in Genesis 3, the rest of their days seemed to be, and God expelled them from the garden, and then he put two cherubim with flaming swords, you read this in Genesis, standing at the entrance of the garden to prevent them from going back in. But most of our life, at least lived out of the flesh, is trying to get back into the garden, trying to go back to the Garden of Eden. And in Isaiah and Jeremiah, there's two, Larry Crabb actually wrote about this and talked about this a lot, and I studied under his counseling program. Two passages in Isaiah and Jeremiah talk about lighting our own fires and then also digging our own wells, cisterns, broken cisterns that can't hold any water. We try to go back to the garden, but we can't get back in the garden because the garden's been closed, and we go this way, forward to redemption. There's a great book, if you want to read just an interesting book. It was written by Paul Brand, who was a world-renowned hand surgeon, and Philip Yancey. It was probably written 25 years ago. Brand has since died of a hemorrhagic stroke, I think after a fall some years back. But he was the first physician to actually believe that leprosy was not a contagious disease. He believed that it was more of a bacteria that affects the nerves and that it is not contagious. So against all conventional medical wisdom, Dr. Paul Brand, trained in the UK in London, moved in with a colony of lepers to care for them. Everyone thought he was crazy. It's like, well, you'll get leprosy. Well, he proved that it wasn't actually contagious. It was a bacteria that affects the nerves. And he wrote a book later in his life with Philip Yancey called Pain, The Gift Nobody Wants. It's been retitled now The Gift of Pain. And he recounts his experiences amongst 3 leper colonies throughout the world, one in the UK, one in India, and one in Louisiana, I believe it was. And he said if there was one gift that he could give his leprosy patients, it would be the gift of pain. They don't have peripheral sensation. Rats can come into the house at night, gnaw off their fingers, and he would see this, and they never felt it. And so then he would have to, as a hand surgeon, reconstruct their hands. So in that book, he paints this fascinating parallel that the best gift that anyone can have is pain. Now, that doesn't mean if you come to me with a wry neck, 45 degrees, I'm going to say, well, just deal with it. But in the back of my mind, I'm thinking about what is that pain's purpose? Is it pointing to something? Is there something else we need to understand? Is there something we need to change in our lifestyle? Again, I'm not suggesting that the gentleman I saw this week had a lifestyle change that he needed to do, but there's so much against lifestyle change. I saw a meme the other day. It was a doctor and a patient. The patient was a woman. And she said to the doctor, does that mean that I need to change my lifestyle for this? And he responds, no, absolutely not. Here's a pill for that. So you see where I'm going with that. Sometimes lifestyle changes are needed. So it's certainly not wrong to want to exist peacefully and to want to exist without pain, but that is not the ultimate goal of our life. And I think sometimes the goal of medicine and the goal of life in general can be this desire to feel good. So I would just challenge you to think about this creation, fall, redemption, and ultimate glorification narrative as a schema by which we can think about life. I'm going to close with 2 things, referencing the Hippocratic Oath. This was something that, this was the oath that Lou Ann and I took from our medical school. It was a modified version of the Hippocratic Oath, and then I'll end with a passage from Philippians. So the oath that we took says, now being admitted to the profession of medicine, I solemnly pledge to dedicate my life in the service of humanity. I will give respect and gratitude to my deserving teachers. I will practice medicine with conscience and dignity. The health and life of my patient will be my first consideration. I will hold in confidence all that my patient confides in me. I will maintain the honor and the noble traditions of the medical profession. I will not permit consideration of race, religion, nationality, ideology, or social standing to intervene between my duty and my patient. I will maintain the utmost respect for human life and its quality. Even under threat, I will not use my knowledge contrary to the laws of humanity. These promises I make freely and upon my honor. I think the words from Philippians chapter 4, again, a very familiar passage, helps us as we think, how do we navigate the ethical challenges? Well, Philippians 4 verse 8 says, "Finally, brothers, whatever's true, whatever's honorable, whatever's just, whatever's pure, whatever's lovely, whatever is commendable, if there is any excellence, if there is anything worthy of praise, think about these things."